Okay, well, welcome. Welcome to the inaugural Nutrition Rounds Live by the National Board of Physician Nutrition Specialists. I'm Daron Kahana. I have the distinct pleasure of moderating today's session. We have a wonderful guest speaker, Michael Rothkopf, who is our past president at the National Board of Physician Nutrition Specialists and also the director of the Metabolic Medicine Consultants, and also a clinical associate professor of medicine at the Sidney Kimmel Medical College, Thomas Jefferson University. We will have three distinguished discussants, panelists, Dr. Xiaoping Li, professor of clinical medicine at the David Geffen School of Medicine at UCLA, and the center director and division chief of clinical nutrition at UCLA. Dr. Timothy Santongo, who hopefully will be joining us shortly, as professor of pediatrics and the director of pediatric nutrition support at the University of Chicago Medicine and Biological Sciences in Chicago, Illinois. And Dr. Omer Dean, a distinguished colleague and good friend here locally at Torrance Memorial Medical Center, and an outstanding clinician that I've had the pleasure of working directly with. I would like to welcome our presenter and our panelists, and I will turn it over to you, Dr. Rothkopf, to give us our presentation for today.
Okay, thank you so much, Daron, and thank you everybody for joining. Thank you for the panelists and for the members and for the team from the ASN for putting this all together. We very much appreciate the support of the American Society for Nutrition, and really we couldn't do any of these types of projects without a lot of help from them. Okay, our first case, and we may really only get to this first case, is a patient that I saw a few months ago who we were able to witness reversal of low cardiac output syndrome after metabolic resuscitation. So my main disclosure is that I am part of a grant that gets support from Abbott Nutrition Health Institute for medical education, nutritional education to physicians. So just let me introduce the topic a little bit. So low cardiac output syndrome, a lot of you may not be familiar with that term, LCOS. It's really a post-operative term. It's something that the surgeons talk about, that the anesthesiologists talk about, the intensivists talk about. It's essentially a reversible form of heart failure that occurs after coronary artery bypass surgery. It's usually seen in the elderly, diabetic, frail patients, renal failure. It's more common in females. It's associated with basically issues during the surgery. So prolonged cardiopulmonary bypass, pump time, prolonged cross clamp times, perioperative blood product transfusions. So these are all surgical technical issues. But another clear possibility and an etiology of concern is the cardiometabolic area, and that has to do with micronutrient deficiencies that can occur in these patients and manifest because the patients are extremely stressed. And if you look at that category, it's more common in the elderly, ethanolic, malnourished patients, just like the syndrome itself. So there is kind of an overlap there. But let me get to the case, and then we can open the discussion. It's a 72-year-old woman who had a defined mid-segment LAD lesion and had pretty decent left ventricular ejection fraction, a low end of normal for her age at 50%. Prior to surgery, she underwent CABG and a few other additional procedures that they often do these things all together. The mitral valve annuloplasty, the Mays procedure, left atrial appendage clipping. But basically it was a CABG, and she developed the low cardiac output syndrome in the immediate postoperative period, post-op day 0 to day 1. And she was found to have diffuse hypokinesis on the postoperative echo. LVF had dropped down from 50% to about 25 to 30%, so roughly in half. and she was basically having trouble sustaining her output. Lactate level had risen to 5.8, and the concern was, what had caused this? The surgeon swore up and down that none of the things that we talk about, cross clamp time, pump time, blood products, none of those things had happened. So everybody was at a loss as to why she was now in this low cardiac output state. And not only was she, it was a question of what had happened, but she wasn't responding to classical therapy. So she was on high doses of suppressors with 3 drugs with epi, norepi, and vasopressin, and she was on 2 inotropes with dobutamine and milrinone, and still was not responding. And so that's about where I heard about her on rounds on post-op day 2 in the CTICU where I do consulting. In this box, you can see her body weight and her calculated energy and protein requirements based on our evaluation. So day 2, we're making rounds, and they look at me and say, Mike, we need this lady to get some enteral nutrition. So can you, make sure she gets an NG tube, and let's start her on some feeding. She's pretty sick and she needs some nutrition. So that message has come across already to the surgical team and the intensivist team. But I was concerned that she was at risk for refeeding syndrome. I wasn't happy about the age and her state, physical state, preoperatively. I thought I got the story from the patient and from the family that she had not been eating well for the days prior to surgery. So I was concerned about that. And then I was also worried about the lactic acidosis, which of course the low flow could cause lactic acidosis, but thiamine deficiency, I knew that thiamine deficiency could also cause that. And when I mentioned that on rounds, you should have seen the rolling of the eyes, with the surgeons and the intensivists, there he goes again with his metabolic stuff. And they're thinking this is purely a pump issue. And so rather than starting enteral nutrition day 1, what I did was to give her what we call metabolic resuscitation. And that was some intravenous thiamine. We choose intravenous thiamine instead of oral because we expect that these patients have some low flow in their splanchnic area, that they're not going to absorb vitamins as well, especially the critical vitamin B1 thiamine. But we did give oral MVI and oral zinc before beginning enteral nutrition. And then a plan was for on day 3 to start her on an elemental feeding, again, because her gut is probably not that functional at this state. And so I wanted something that would be relatively easy for her to absorb. And here's what happened. We were all surprised. Day 3, we all make rounds. And I usually get there early, so I already knew a little bit about what was happening. But we start rounds at 7 a.m. in the CTICU. And suddenly this patient, I hear that right after beginning therapy, within a few hours, her cardiodynamic position improved dramatically. She was able to wean from pressors and inotropes. By the time I saw her on postoperative day 3, her repeat echo showed a marked improvement in her LVEF to 45, 50%, and her lactate had dropped to 2.3. So really, it seemed pretty clear that there was a response to the metabolic therapy. Nothing else had been working for this patient until I started the therapy, especially the thiamine. Now, before I started medications and the thiamine and the zinc and the MVI, I did draw pre-op levels of thiamine and zinc, and sure enough, they came back later to show that the patient was completely devoid of any detectable thiamine. And we do RBC thiamine in our hospital, and so that's a pretty good indicator. And severely low in zinc, the RBC zinc of 19, normal is 60 or 65, and between 60 and 130. So on that basis, we continued to give her metabolic therapy orally past that point, and by the time she was ready for discharge, a repeat echo showed nearly normalization of her ejection fraction and no abnormalities of a regional wall motion and normal right ventricular movement. So I'm going to pause at this point and see if anybody has any questions about the case itself before we go into the literature review.
So Mike, I immediately got a question from one of the attendees. Why do you think her thiamine level was so low?
Okay, excellent question. Actually, if you look at thiamine in hospitalized patients, its incidence of thiamine deficiency is fairly high. It's in the 30 to 40% range if you look at all hospitalized, especially hospitalized elderly. If you look at patients with congestive heart failure, outpatients, it's pretty low. It's something in the range of 3-5%, but it's much higher in the hospitalized patient. And we think that it may be a result of the use of diuretics. And so especially loop diuretics and thiazide diuretics can deplete the body of thiamine, but it may also just be poor nutrition or poor absorption. So those are some of the background reasons that are talked about in the literature for thiamine deficiency in this type of patient.
Yeah, and I'm getting a lot of why questions, Dr. Rothkopf, and I will just preface it to everyone that much of the why is difficult to answer sometimes. We're very good in measuring quantities and levels, but sometimes it's hard to know why patients are deficient in a single nutrient. So Dr. Tayek, also a local colleague here in Los Angeles, asked, why check zinc? What role does it play in cardiac function?
Another excellent question. And I checked zinc in this patient, and I do it fairly often when I suspect that there is a micronutrient deficiency, when I suspect the patient's at risk. And I will say that we check the zinc with maybe 10 or 15% of our patients when I'm looking at the patient and see dry skin or the history of just very poor intake. This patient really didn't have those things, and I don't think that the physical exam can really point you so much to measuring it. But I was just, well, we'll call it dumb luck. I was just concerned about the patient clinically, and I was shocked to see that level. I want to tell you, everybody, that I'm somebody who gets a fair number of zinc levels done, and you'll see them in the 40, 50 range. Very rare to see something like this with a 19. That's a severely low zinc level.
Yeah, I will go ahead and continue, Dr. Rothkopf, and we will have more time for questions. And also, I want to involve our panelists.
Okay, so we actually did a literature review on this case because we were fascinated by what happened, and this was a lot of feathers in the cap because I could make rounds a few days later with the team and tell them this patient was really quite depleted, and that part of her response we think was clearly the replacement of these micronutrients. There's a growing literature now on micronutrient deficiency as a cause for reversible heart failure, and I think that's one of the important teaching points of this case. That cardiac patients are known to have a number of micronutrient deficiencies, not just thiamine, but also vitamin B2, B6, folate, B12, vitamin D, CoQ10, carnitine. In addition to zinc, there's also selenium and, of course, iron. And there are studies on replacement of all of these nutrients. It's not totally clear that you can see statistically significant results, but I think if a patient is depleted, it definitely makes sense to replace them. Now, the role of thiamine, very, very important in the entire body, especially important in high energy organs like the heart. and I'm sure I don't have to remind the group that, without thiamine, you cannot properly produce ATP. You cannot get glucose to break down products as acetyl-CoA to enter into the Krebs cycle, because thiamine is part of the gatekeeper there, pyruvate dehydrogenase complex. And then thiamine is also important in the Krebs cycle itself within the mitochondria. So ATP production is tremendously impaired in a thiamine depletion. Now, zinc deficiency, on the other hand, is a less commonly recognized but also understood a mechanism for the development of a cardiomyopathy, pro-oxidant type of cardiomyopathy phenotype. And there actually have been some reports of this, but most incredibly, a recent patient report just this previous year, in which a young woman with anorexia was found to be zinc deficient and have congestive heart failure, and reversed with treatment. So I did pull up a couple of just the pathways to show this is the pathway of the thiamine, and then this would be some of the issues with zinc. Very interesting that how zinc is a cofactor for nitric oxide, and also a crucial part, obviously, of superoxide dismutase. So without zinc, heart will not function properly.
Okay, well, I'd like to open up some questions. We're getting some fantastic questions from our audience, and we are actually quite full. We have quite a few attendees, and our panel is full as well. So let me address some questions. Maybe I can ask Dr. Santongo, if you don't mind answering this one. Can zinc be given IV, and how do you dose it PO? Do you have a favorite way to calculate needs for PO zinc supplementation?
Thank you very much. And first of all, thank you, Dr. Rothkopf, for this very interesting case presentation. I followed it. I'm a pediatrician, but the issues about it are pertinent even to pediatrics. So traditionally, I have replaced zinc orally, and we're always careful about zinc replacement because it counteracts with copper. Therefore, if you're too zealous in replacing it, you could tip somebody over into a copper deficiency. So those are factors to consider. In parenteral nutrition, there are IV formulations of zinc, but traditionally we replace it. If you're in a replacement mode, we do an oral supplement presentation. There's the over-the-counter zinc sulfate that we use, and that seems to work well for most of our patients. So that would be my comment about zinc replacement.
I would just want to add, don't forget the food, particularly meat. Feed the patient, so that way you at least not falling behind. It is hard to just rely on supplement zinc alone.
Thank you, Dr.
If I can just piggyback onto that, I tend to use 220 milligrams of zinc sulfate per day, and I usually kind of limit it to a 2-week replacement, and then we can follow up and check levels again. Does that sound, Dr. Rothkopf? Is that similar what you're doing? Or?
Yes. You'll find that in the hospital formulary in most places, that 220 milligram.
And Dr. Dean, maybe I can follow that up with another question from Dr. Nanda. Can this cause effects on the colon, cause dilation, a pseudo-obstruction-like state? Have you seen pseudo-obstruction in the colon as someone who I know is very much on top of gastroenterology, although you're not a gastroenterologist yourself? Do you see pseudo-obstruction in these kinds of states?
You mean, we're not talking about with replacement. We're talking about in patients who, Yes, yes. So that's actually a very good point, that patients who are in critical condition, who you highly suspect as having or are
Hello?
proven to have refeeding syndrome. Hi, can you hear me?
Yep, we
Yes.
got you now.
Okay. So that's actually a great question. You know, in the ICU, in patients who have refeeding syndrome, or even if you highly suspect refeeding syndrome, in addition, this is about muscle contractility. Now, the heart, of course, low cardiac output, like in this case, is dealing with, you know, it's not smooth muscle, but the GI tract, I find ileus more so than obstruction, pseudo obstruction, tends to be very common. And so, like Dr. Lee mentioned earlier, that you want to start feeding, and that's probably of utmost importance. But I tend to start slow. So I would start with just trickle tube feeding at 10 ml an hour. I like the idea of the elemental feeding, or even like a peptamen, a peptide, you know, hydrolyzed peptide formula, something like that. And then you gradually monitor how they're tolerating it and you go up on it. So I wouldn't be too, you know, overzealous about starting too high of a rate too soon for that reason.
Thank you. Dr. Lee, let me also follow up on that with ileus and pseudo obstruction with refeeding syndrome and severe malnourishment after cardiac surgery. Do you think bacterial overgrowth, small intestinal bacterial overgrowth, could be contributing to the poor nutrient absorption, specifically of zinc?
I think it definitely could,
Sure.
but I really think it depends on each individual patient's preoperative overall conditions. I think that this case really brought up a very important issue for all of us practicing nutrition, and that is the new concept of prehab. That is, if it's all possible, have the patient at the best nutrition conditions before they go into any of the major surgeries. Obviously, this patient has been on the verge or very marginal with her overall nutrition conditions. That is why the major surgery brought upon all we see today. And, you know, interestingly, I would want to ask Dr. Rothkopf, do you know anything about this lady's neurological symptoms, mental states? As we all know, thiamine, you know, wet berry is heart failure we're talking about. But the other thing is neurological symptoms. We actually have very good data just from our clinical practice, particularly this patient in nursing home has actually much higher prevalence of thiamine than we ever thought. So this should be also part of the workup for any rapid decline of memory or other neurological symptoms.
Yeah, she did not have any manifestations of Wernicke's, Korsakoff, or any peripheral neuropathy. And that was another interesting aspect, that it was really a cardiac condition. I think that it was just a very acute compromise, and then the fact that her heart was under stress and her heart needed to produce more ATP at that moment, recovering from the surgery, and then just couldn't meet the demand because of the lack of thiamine.
And Dr. Santongo, if I may ask you, since I think Dr. Lee brought up an excellent term, I really like it, the prehab. And you also, as a pediatrician, mentioned how such an entity is an adult entity after CABG, but there is some literature on congenital heart conditions that necessitate surgical correction, and those patients post-surgery can also develop LCOS. Is there a role for prehab in pediatric patients? And really, I want to ask all the panelists and Dr. Rothkopf, what would be your prehab panel? What would be your nutritional status panel that you like to see on most patients that come through your clinic? What nutritional markers do you rely on the most? Obviously, you can't check them all.
So prehab is a good terminology, and I just want you to just clarify a couple of things. Prehab, because there's this era of, you've heard of eras, so you're really not talking about ERAS, you're really talking about prehab. Just to make sure that. Anyway, in pediatrics, in terms of a nutritional panel, I really have found that just the gross growth measurements are just much more informative, because a number of the labs are impacted by the state of the patient. For example, if there's anything inflammatory present, some of the labs are impacted. For example, I use a lot of prealbumin to guide me about somebody's nutritional status, but I also recognize that if the children if there's any inflammation underlying their presentation, sometimes those numbers are impacted because prealbumin ends up behaving like a negative acute phase reaction. Yeah. So you run into those issues. So we basically feed them as well as we can to get their weight. And if their weight is really not responding, sometimes we even recommend the surgery sooner, because many times it's the underlying condition that's impacting our ability to nourish them. So it's more judging, you want them as well nourished prior to surgery, and standard thing like CBC, albumin, you want them in the best place possible. But if you're failing to accomplish that, then sometimes you just have to do the surgery sooner, because the underlying condition is just not allowing nutrition to be administered effectively.
Excellent. And Dr. Dean, so prealbumin and CBC are definitely two of my favorite things to check. Anything that you normally look to in advance, or what is your clinical approach?
So similar. I like the prealbumin, but I always point out to people that you can't trust. Obviously, I always kind of steer people away from checking albumin. That tends to be the first thing on most people's minds. I check prealbumin, but I like to follow the trend through their hospitalization, maybe once a week or so. Because of course, as you know, high CRP, high stress environment, acute illness, an isolated prealbumin isn't going to give you the whole picture. But that's probably my most important one. I like to check iron studies, ferritin, vitamin D, 25 hydroxy vitamin D level. I do still check just kind of overall markers like that. But I really do begin, with a good physical exam. When you first see them, that really tells you the picture of how their nutritional status is, and the labs kind of help reinforce that.
Okay, and Dr. Lee, same question for you.
Oh, sorry, I was on mute. I actually start with a very old-fashioned good history, and to know the patient as much as possible. Also assess functional status and review the overall dietary intake. And from there, then I would agree with everyone have just said. I would order basic metabolic panels, pre-albumin if I see a need. I would also LFTs. I would start from there. If any indication from the above test, then I'll move on to check others, including the more common iron deficiency related, and can check zinc or history or physical indicated certain vitamins. I'll be doing that a second round.
Excellent. Thank you, Dr. Lee. And Dr. Rothkopf, I'll throw it back to you for some conclusions and also your clinical approach.
Okay, well, I know we're running low on time. Well, basically, I think the point is that be aware of this and think about it. This just shows the role of the metabolist, the role of the physician nutrition specialist, and how much we can contribute to so many of the patients that are seen in the hospital, in the ICU, and in this very intensive place, the cardiothoracic ICU. Really, I feel there's a big role here for us to utilize more of the knowledge that we have about biochemistry and metabolism for the benefit of the patient. And so I think this case really points out the advantage of having that kind of input. And I think really that the surgeons and the intensivists, the nurses, and everybody, after seeing the response in this case, I think really understood why we're there to help them. I think that we're going to skip. Obviously, we're out of time already, but I think we do want to wrap up because I think we don't have time for the second case. We're going to maybe do that on a future meeting. But I do want to get a plug in here for our upcoming CME accredited course on evidence-based nutrition care, and that's called RX Nutrition. And I also want to recognize the support of the Abbott Nutrition Health Institute in what we were doing with educating physicians on nutrition in this platform.
Thank you, Dr. Rothkopf. And I also want to thank Dante Preciado and Gwen Twillman for being so instrumental in organizing today's inaugural session of Nutrition Rounds Live. And you put in a little plug, and I'm going to add a little tease about next session, and you kind of briefed through those slides, but those slides are regarding nutritional support for COVID-19 patients and maybe a brief review of the literature that is emerging. I think that when we reconvene in next quarter, there'll be a lot more information. The new wealth is health, and it's amazing how we are now seeing a clear correlation, at least the literature points out to a significant risk factor that obesity plays in morbidity and mortality with COVID-19. And we're going to learn a lot more about that. But while we do, I think we are seeing some response in our patient population, recognizing that nutrition plays a significant role beyond the obvious. And this is a great opportunity for us as nutritionally minded individuals and clinicians and physicians who are out there in the field to really try to get our patients on board with a more well-balanced nutrition and to get more physicians interested in screening for malnutrition and utilizing medical nutrition in the care of their patients. So thank you, Dr. Rothkopf. This was an excellent presentation, really highlights the importance. And thank you to our distinguished panel, Dr. Lee, Dr. Sintungo, Dr. Dean, who's actually traveling and took time away from his family. Thank you, all of you. And thank you to our audience. We had quite a few attendees, and thank you, Dr. Tyack, for all of your excellent input and all the other attendees as well. If you have further questions, please do not hesitate, reach out to me and I will present them to our panel. So with that, thanks again, and we will sign back in using a different link and continue our monthly conference. Take care. All
Thank
be
you.
well.
Bye-bye.
Thank you, everybody.
Thank you.